All right. Thank you, everyone, for your patience. If you've been patiently waiting for this live to beginning, but I'm very excited. As you all know, technology works sometimes when you want it to, and sometimes it just doesn't. And so I'm really excited today, and I know this is a topic that is filled with, we talk about HIE being in the weeds and not a lot being clear cut, but the causation question comes up almost every single time with families because families are looking at what happened, and this is a very unexpected journey that when HIE enters your life. And so I'm really excited for our community to bring Dr. Mark Scher today to everyone and your incredible expertise to this conversation. And really, the genesis of this event is really from a conversation that Mark and I had last year at the Child Neurology Society meeting, and talking through, the multitude of causes HIE and, counseling families and what families ask and what they understand, and really trying to, help families, weed through and get a better idea of what could have happened to cause their child's HIE, the misperceptions that exist out there, the misinformation that unfortunately exists out there, and really getting a better understanding of how to do their best to work with their medical team to understand these, this very complex diagnosis, and help them get answers, because a lot of times we know that this can impact family planning and impact your whole life. Speaking from personal experience, my child who has HIE was my first. And he unexpectedly stopped moving at 37 weeks. So we didn't really have an indication, that anything was wrong until it was. And, the big question was, can it happen again? What happened? Is there something, that I need to be aware of to seek additional care when planning a next pregnancy? Is there, an undiagnosed something with me, with my husband and I, what is this and how can we do better? And I know a lot of people are in the same situation where it might not be clear cut. So Mark, I'd love for you to, share with us a little bit about your background and your, research and clinical interest. And I know you just have a breadth of amazing experience across fetal and neonatal neurology. And I would love for you to share that about your background with our community.
Thanks, Betsy, for inviting me, and for everyone. This is your HIE Awareness Month, and this is very important to discuss and to move forward. So I'll do what I can to contribute. So for everybody's reference point, I am a child neurologist. I became one quite a while ago. My training ended in '83, but I trained before that. And my particular interest has always been the newborn, and then by extension, the fetus. So my formal training got me started, but then my faculty training, first in Pittsburgh and then in Cleveland, continued my career-long training, which it continues even now. And so in Pittsburgh and then followed by Cleveland, I worked with two obstetrical pediatric centers. I worked at McGee Women's Hospital in Pittsburgh, if anybody knows Pittsburgh. McGee Women's Hospital is a fantastic place for women's care, and it connected to Children's Hospital Pittsburgh. But then I moved after 14 years to Cleveland and teamed up with the Rainbow Babies and Children's Hospital neonatal team that was physically connected to an OB hospital called McDonald Hospital for Women. Why I'm telling you all this is that my understanding, my knowledge of parents and what they go through with children who experience encephalopathy in the newborn period has always been merged with my appreciation and respect for the woman who has gone through pregnancy together with her partner, had a reproductive history before she conceived, and that goes into my opinions when I offer my consultant advice. Now, I'm going to introduce a word for everybody called uncertainty. And I want everybody to know that besides parents being uncertain about why their children have encephalopathy, doctors and nurses themselves have uncertainty, because in real time, we sometimes will be introduced to your baby after resuscitation when your pregnancy was okay, to the limits of what pregnancy monitoring can tell you. So, we have the same uncertainty you do. So I'm going to introduce not only the word uncertainty, but I'm going to introduce something that I've learned from a lot of lay people like yourselves, together with professionals. And some of you probably know about child life. Child life is a specialty within children's hospitals. And I had a good friend who's now passed, Mary Barkley, and she was a head of Rainbow's child life. And I learned a lot about how they were kind of the go-between when parents were under stress when their babies or children were sick. Well, I think that this sort of approach lends itself to not only how do you deal with uncertainty, but how you can create shared decisions among families, parents, and nurses and doctors, because we all don't know the future and we all don't understand why their baby is this way. Now, we're trained, and I'm not a neonatologist, but your baby's born with low ABGARs. Everybody knows what an ABGAR score it is. They need resuscitation. Okay, so they're depressed. They may be unconscious. They need to have maybe a tube put down their throat. All these terribly scary things. However, the question is why and when, and that's the two things we're going to talk about today. Because yes, there may be some issues in the last minutes or last hours of active labor that may have something to do with making your baby look sick, and actually not even be the cause for why the baby is injured. But I will share with you that a lot of babies look sick and then they're not injured, which is wonderful. Babies do recover with the help of resuscitation. But there are other babies that fake us out. And this is the uncertainty factor. So they fake us out because they look sick, because being pushed out of a small space, the vagina, or if they go through C-section, is pretty stressful. And so that transition makes them look sick, even though they may not have brain damage. So you gotta wait till the smoke clears, support the baby. And then when you speak to the parents who are clearly in shock because they didn't expect this, you got to explain to them, we're uncertain to why, and we want to collect information. This is the key for why the Hope for HIE group is so important as an advocacy group and an educational group. Because when we start talking about the baby, and I'm not seeing the baby during resuscitation, I'm a neurologist. But at McGee, I was usually right there in triage watching them be resuscitated, but I at least know the information shortly thereafter. The question is, how much do you know? Well, you may not know enough, and so you give the baby what you know you can help them. You give them a ventilator, you give them fluids, you give them epinephrine, you give them seizure medications, and now we put these children on therapeutic hypothermia. Okay, so you cool them. Cooling is great for some babies, but not all babies. Why? Because the timing of their reason for a brain disorder and the reasons have not been fully studied by those who publish the information about cooling. But that doesn't change the uncertainty of not knowing the future. So you put your child on hypothermia now, and you wait your 3 days, and you keep them cool, and you keep them calm, and you don't stress them, and then you warm them up and see how they're doing. Well, during this period of 3 days, you're learning more about your baby. And I'm the consultant who makes rounds with the nurses and docs, and I meet the parents at bedside, and I learn that maybe there's something unusual about the baby's exam that I point out to them, or there's something unusual about the imaging of the baby's brain, like a sonogram, or there's something unusual about the type of organs that were affected, whether it's the kidney or the heart, etc. The point I'm making is, I'm Sherlock Holmes. I don't know the future. I'm making kind of deductive thinking or reasoning based on limited information, the uncertainty factor. Well, if I continue to watch your baby hopefully recover, more information will appear. They'll be stronger. They'll be able to get an MRI, maybe on the 4th or 5th day of life, which is of the brain. And then the key is, and Betsy knows this because we talked about this in Vancouver, for me, the most important piece of information to reflect on is based on the pathology of the cord and the placenta. Now, I'm going to say this very respectfully. Not all hospitals have special pathologists that can look at this information. And some of you may have had your babies in lower level delivery hospitals where the placenta was not saved. I understand that. If I can give any advice to Betsy and your group, I think you should be educating us, healthcare providers, to save the mother's placenta, to look at it carefully, because at 7 days, when I looked at a binocular microscope with Ray Redline, he's a fantastic guy in Cleveland who's smart with placenta. He would show me with a binocular microscope things about the placenta that would maybe change my ideas of why your little boy or girl was so sick at birth. There may be something about the placenta that suggested infection, even though mother didn't have infection. There may be some suggestion that the placenta was small and it was not formed well because of injuries to the blood vessels of the placenta. I could go on, but the issue is, I didn't know this on hour 1 of life or when the baby was on hypothermia, but at 7 days, 5 days, when the placenta comes back by microscopic analysis, I do know that. Well, that may be important to then feed into the discussions that I'm having at bedside with the parents. And you guys have all been through this if you're parents of kids who had HIE or encephalopathy. It's not only the bedside meetings I've had with parents, but it's the group discussions where we sit in a conference room. It's a scary time. And the parents and maybe the grandparents and other family members are surrounded by not only your primary nurse, but all the social worker and the attendings and me. And so I will go through a series of meetings through the step down and convalescent stages of your baby's time in the NICU. And they'll turn to me usually and they'll say, well, Mark, could you explain to Mr. and Mrs. Smith why the baby had encephalopathy? And if I knew more at day 14 or day 7 or day 12, I will try to, in as clear a way and as kind a way as possible, explain what I do and don't know. Because remember, the uncertainty factor still remains. But usually by the end of hospitalization, I usually have to say, yes, this may have been due to problems that were labor and delivery related, or I might say other things contributed to that. Now, I may not still know. And so I'm hoping that I have a good relationship with mom and dad and family, and I get to visit with the baby after discharge. And so my job as a neurologist continues. And I may change my opinions about things as new information comes in, as the child becomes a toddler or, an infant. I'm going to stop for a second. Betsy, should I keep going, or is this?
Yeah, I mean, I think this is really great because this is really working through, I think, an insight of what you as a physician goes through with the evaluation process, the communication process. And this is kind of like behind the curtains where, I don't think we as families get this insight often of what this process is. So if you want to keep going, that would be fantastic.
Well, I'm going to try to hopefully get people to ask me questions because they've had their own experiences. But one of the things you should hopefully realize that's changing, and the Newborn Brain Society, which Betsy and I are members, is a really good organization that I'm very supportive of. We need to understand how to share information with our families, knowing we're uncertain about all the answers. And that shared decisions, that includes your values and beliefs as parents. So and I'm saying this in broad ways. I'm not talking about just religion or just culture, but people are smart. They may not be doctors. They may have gone through a high school and even a college education, but they have their own values and beliefs that allows them to think about why their baby's sick. Well, I have to respect that as I'm trying to figure out why your baby is sick, and hopefully we'll get better. But we need to work together. If we start to have distrust, or more concerning for me is when I used to teach my residents and faculty, if we become less compassionate, or we're rushed because we're tired, or we have lots of patients to see, that's not good. And so what I hope will happen in situations such as each of you in your own lives have experienced is understand you're not alone. Use your nurse as probably your best friend. Make sure that your primary nurse at bedside understands your fears, your concerns, your questions. If you're angry, if you're confused, and then share that with your neonatologist and with anybody else like me who comes honestly, so we can share with you what we do and don't know. Now, ego is part of it. I get it. And doctors and nurses think they know everything. Well, they don't. And I'm not here to say I know everything. And I try not to give that impression. But you have a responsibility to tell us, I don't understand why. Or now that I'm talking to you today, maybe you'll be educated and Betsy's group can help the next generation of parents ask about the placenta and the cord.
Mm-hmm.
Ask them about things that, well, let me go on with that. I mean, you may want to talk to your OB because they may have been just as surprised as you that they went through the procedures of delivering your baby and they were not expecting the baby to have low Apgar scores. They may not have the answers, but at least you can get some answers. You can at least get them some honest responses from them as long as they're not defensive. Because one of the things that Betsy wanted me to touch on is the medical legal aspects of this. And I'm not saying this with any disrespect. Doctors and nurses make mistakes. And I started being told that in my medical school days in the 70s. We're human beings. We miss things and we make mistakes. If those mistakes were contributing to injury, well, you have to be responsible. But on the other hand, the uncertainty factor has to be considered because I'm not Gandalf from the Lord of the Rings. I don't have the Orthanc stone where I can look into the future and tell people what's going to happen in the future. That's something that I think parents need to understand about uncertainty, that we professionals can't know everything. But that doesn't mean we can't be honest and tell you we don't. So you can at least understand that babies can look sick. They may not have injury. They may have injury from an acute problem, or they may have injury from a past problem that made them not negotiate being born real well. You know, it's tough to be born. I had a mother, and she went through a birth with me, and it was tough. My brother's 5 years older, same thing. My Apgars, I have no idea what they were, but my Apgars may not have been perfect. Why? Because I went through the birth canal and I had to be squeezed out of a small space. You can be symptomatic and be lower tone and be less conscious or unconscious without brain damage. And that's something I want to share with all of you, because you were scared. You saw your baby floppy, blue. No question you're worried about an acute problem, but that baby may still be okay with no brain damage, but still was recovering from a pretty traumatic event. And then recovery happens. You know, HIE, if we take that hypoxic ischemic encephaly diagnosis, that's only one of many. But even if we take HIE as a diagnosis, only 1 or 2 or 3 per 1,000 live births, if you're a full-term baby, experience HIE. Well, guess what? Only half of those, so taking half of 1 out of 3 per 1,000, only half of them will have brain damage. The other half won't. And this is before hypothermia. With hypothermia, that does help. But it's such a rare needle in a haystack surprise for even providers, let alone parents. We need better tools. We need better tools to diagnose you during your pregnancy. I'm talking to mothers. We need to diagnose better how to intercede with drugs during pregnancy, which we don't have, by the way. And we need to know when babies will have encephalopathies from other things other than, quote, a blocked cord or an abruptio placenta or a uterine rupture. Those are the big 3 that we call sentinel events. It could be from infection. Mm-hmm. I've written on this, and many people have. Fetal inflammatory response is a big, long name. It means chorioamnitis. It means funicitis. Those are the technical terms where you have inflammation of your placenta and of your cord. Well, guess what? This is a mimic of HIE, but it's not HIE. It walks like a duck and looks like a duck and sounds like a duck, but it's not a duck. It's not HIE. It's FIR. It's fetal inflammatory response. I wouldn't know that unless mother came in with a fever or uterine tenderness or their amniotic fluid was smelling bad. It may wait until 5 or 7 days when we see the placenta, and the placenta shows a grade 2 or 3 chorioamnionitis and funicitis. Oh my gosh, that would change my whole discussion with the family at the bedside and in conference if I knew it was fetal inflammatory response. Again, Betsy, anything you want to add or you want to guide me?
Yeah, I think that's such like a good differentiator too. And, I think what's really confounding with HIE is that so many things can co-occur as well. And that's where, trying to figure this out is very difficult. Just out there in general, as we've been working to try to build educational resources and health literacy in our community and looking at, the multiple, multiple things that can and go wrong and co-occur. So sometimes that's, because for a while, people lumped so many things with HIE, neonatal stroke, or, IVH, other things that happen.
Yes.
And then, looking at, the in utero, the core of the placenta. But, there's things that we know too, where some of the maternal fetal overlap, can lead to, so infections can lead to HIE sometimes, and sometimes they don't. And, it's just really difficult to tease those out. And then looking at, prevention, because that's, the ultimate is how do you prevent? And, we have a question that came in that I think is really, and I think you talked a little bit about this, but we can go into it a little bit more of what is the diagnostic tool quality of looking at cord and placenta like through routine ultrasounds, and I follow quite closely. The NIH has the Human Placenta Project. I know one of our parents has participated as well in that with one of her subsequent pregnancies with, I think she did like fetal MRI during her pregnancy, as a part of it. And they're looking at all these different things to improve. But, can you speak a little bit about just the state of, prenatal diagnostics?
Yeah, that's a really good question that one of your members, your participants asked, because we do use fetal surveillance to look at the placenta through sonography primarily, and sometimes the Doppler flow by looking at the blood flow through the umbilical cord, etc. But I want to share with everybody that I am a fetal neurologist as well as a neonatal neurologist. So I've met my share of pregnant women, sometimes as early as the first trimester. I understand what OBs and MFMs have as tools to make sure that the fetus is in a state of well-being. You can be in a state of well-being and still have a brain damaged baby. But you're asking a very good question. So let me give you an example. And Betsy, you mentioned the Human Placenta Project. Well, the United States has a Human Placenta Project, and a lot of other countries do too. China has one, and a lot of big countries and small countries do. The placenta is a really important diary. I always tell parents it's a diary. You open up the book and you read about what your pregnancy was like as best you can. Now, it doesn't mean that everything you see in a placenta that's abnormal equals an explanation of why your baby has brain damage. Because a lot of babies are resilient and others are vulnerable, and they may not succumb to those problems. We are not yet, unfortunately, in a position to do fetal diagnosis to then intercede and give a drug that will change things. I'm going to give you an example because I'm an optimist. I'm a pediatrician, so I'm a universal optimist. I think in the future we're going to eventually have things such as Catherine Limperopoulos is a name I'm going to share with you. Catherine is a researcher at National Children's Medical Center. She's married to my good friend Andre Dupasse, but Catherine is an incredible scientist. She was a former OT, trained in Canada, and she has developed a research lab that looks at fetal MRI of the placenta and of the brain combined as early as the early second trimester, 15 weeks, 20 weeks. And so if we knew way back then that there was a disorder of the way the placenta implanted or how the cord twisted, or there was a change in the flow characteristics of the placenta, then the big question is, do we have drugs to reverse it? We don't yet. I'm not a pessimist. I think I'm an optimist, but you first have to get a better test than an ultrasound, than sonography. And eventually, everybody, whether you're poor or rich, should have a fetal MRI of their placenta and of their fetal brain and of the heart and the gut and everything else to make decisions during fetal life if you have to give treatment. But we're not there yet. If anything,
and
go ahead.
Oh, I was going to say, that reminds me of a parent that asked a question ahead of this, who I know will be tuning in later, who couldn't make it live. And she had IUGR with her baby, and we get, some people that, will have IUGR babies, but, many of them won't have HIE, obviously. But, just the question of, and I remember in one of my pregnancies, like the measurements of one, because you typically only get like 1 or 2 ultrasounds if you don't have any risk factors. And then like how, they do the fundal height and all those things, but it still is a very imperfect,
it is
kind of rudimentary system of tracking.
Well, God created mammals, and we are mammals.
Mm-hmm.
That means a mother has to conceive a child with a partner, and that baby goes through gestation, and in our case as human beings, 9 months. And during that period of time, there's this orchestration among the mother, the baby, and the placenta to stay healthy. I consider that my patient. So when I see a fetal consult, it's called a maternal placental fetal triad. And so my patient is the triad. Well, getting to IUGR, what happens if I am told at the anatomical survey at 22 weeks, the baby looked a little small, and then they did a third trimester ultrasound at, let's say, 32 weeks, and the baby fit criteria of being less than the 10th percentile, which is called small for gestational age, or less than the 3rd percentile, which is called intrauterine growth restriction. That does not equal brain damage. It means a higher risk for brain damage and other things, but not in every baby. Why? Well, because you as a parent and your partner gave them genes, and they have their own genes that make them either resilient to stress from being too small or maybe making them more vulnerable. So we haven't gotten into genetics yet, but I do want to say that growth restriction is an important variable. I use it in my uncertainty principle when I do my workup. I want to know, was the baby stressed by being growth restricted? You guys don't know about this, but I'm going to teach you something. There's something called the BMI of the newborn. You know what a BMI is, a body mass index. If you want to lose weight, you know what that is. Well, babies have a BMI that I use when I do my consults. It's called the ponderal index. Okay, what does that mean? You may not be IUGR, you may not be SGA, like I just said, but if I take your baby's weight in the numerator, and then I take your baby's length cubed in the denominator, and I come up with a ratio, that ratio may tell me that your baby may be growth restricted, but a little more subtly than would have been picked up by being small for gestational age or growth restricted. That's something you guys know about from your sonography. In sonography, they look at the baby's head compared to the baby's arm length. That's a ratio. Well, ratios, we need to improve our patient care. So I begin to ask as a fetal neurologist, well, what is the growth of the baby's brain compared to the belly, compared to the chest, compared to the length of the femur? Because those may be clues of growth restriction. Now, growth restriction could mean stress without brain damage. How to separate those who have brain damage from not, we're not there yet. But you're asked a very good question. I'd like to extend it to say that when I see a baby at birth, I look more than simply growth restriction based on simple measurements of body weight. I compare it to length, and I ask the question, was the baby stressed in utero? Because The baby may have been stressed without brain damage, but because they have a ponderal index that was reduced, they get into labor and delivery, and you as the mother had an abruptial placenta. And all of a sudden they were deprived of blood, and they were already compromised because they were smaller because of something inside the womb.
Mm-hmm.
They weren't able to resist. They weren't able to resist the damage that occurs because of that acute abruptio, because of a chronic problem that made them more vulnerable. If you follow me, so.
Yeah, I think, it just gets into the layers of the onion and how truly difficult, sometimes it can be to look at all of these different factors, speaking from personal, experience with my pregnancy with Max. There was a size difference that was noted between my first and third trimester ultrasound, and everyone's like, well, we could have measured it wrong the first time. I had a very healthy pregnancy, but I was also under a lot of stress in my career. There was just like a lot of things. And then, afterwards you're like, oh, wow, that can contribute to my placenta failing, which was undetected because of multiple factors. And then we get into things now, like in this, it's 2024 and 2020, we introduced another global infection that has negatively impacted maternal health, which can stress the baby. And we've had many families come in that, moms were in the ICU, and unfortunately their child experienced, deprivation because of the mother-baby dyad. And they're looking at, and it's been, there's now research showing a lot of, that there is, unfortunately, that can not just prematurity with COVID, but also, higher incidence of HIE, which makes sense when you're looking at how do we, and great question that just popped in too, seeing the increased occurrences of HIE with COVID because of the stress of the pandemic or COVID itself. And yes, there is published data of that. And that is something that, we added to our list of causes because it's just we're always evaluating and looking at, what data is coming out. And we shared some of that earlier this year with our community as well. Some pretty significant international studies looking at mother-baby health and COVID and, all of the things. So it's always a moving subject.
So Betsy, you and your members have brought up some very good learning points that we healthcare providers and scientists are now exploring because of uncertainty. And that is the newest congenital infection called SARS-2 that leads to COVID. I'm an old guy. I was trained with the torch infections from the 70s, which means herpes and toxoplasmosis and cytomegalic inclusion in virus, etc. Well, it's now Zika virus. It's all kinds of pathogens. COVID was terrible. It's a terrible virus. It affects the placenta, everybody. You should know that along with other types of infections, COVID is really, it depends on the type of variant of SARS, but it can hurt the placenta by fetal inflammatory response, which can compromise your delivery. It can also make the mother very sick. So your point is well taken. COVID has really opened up our eyes. I want to share something that Betsy brought up, and that's the term stress. Stress is not simply a psychological term. It is a psychological term, but stressors are something that Mother Nature has created that can sometimes be a positive thing to make us stronger. It can be neutral. It can go either way. It doesn't have to give you a positive or negative thing, but it can give you negative effects. Now, I'm not going to make everybody do a homework assignment and read my paper, but I wrote a paper in Frontiers in Neurology in January. It's a big, long paper for doctors, nurses, and scientists on toxic stressor interplay. And I wrote that paper because I'm an old guy who's been around for 40 years. And I've realized that the literature across disciplines have taught me to understand that stress can happen from a number of different things. I'm going to mention a few of many. The stress of being pregnant. I'm not a woman, but to adjust your body to have another little living being inside you is stressful enough. If you go into pregnancy stressed by other things, and Betsy, you mentioned your career, but it's not just that. It could be um, a problem that you're having at work, a problem you're having with your marriage, a problem because you inherited something as a child and adolescent that maybe made you anxious and depressed with a mental illness that may have caused you to use substance like marijuana. And I'm not saying this because you're a criminal. I'm saying this because you try to use it to self-medicate. We have in the United States a new study. It's an NIH study called HEAL. I think, Betsy, you probably know a little bit about the study. It's a study that involves about 15 or 20 different centers around America that are looking at healthy babies of mothers who were exposed to COVID, but who had other stressors that could involve substance use, particularly opiates. Opiates is a biggie now. But it could be in the context of mental illness. It could be in the context of poverty or lifestyle choice. If you don't have enough money, that's stressful enough, and you can't support yourself and being pregnant. But you don't eat right, and your nutrition is not optimal. That's stress too. So stress is a pretty complicated thing. I have a lot of insight only because I'm a student. I'm always reading, and there are so many people around the world that have studied the effects of stress. Mm-hmm. Well, mothers have to accept the fact, and now that gets into my work as a fetal neurologist. When I do a consult, the last thing I want to do, even though I have to give news that may not be good news, is to stress mother out while she's pregnant. But that's a toughie, because I still have to impart information and share that information. I hope this is helpful, because I think that stressors happen in life. We're all pretty resilient, and we can adapt to those stresses. But there are over 70,000 xenobiotics in the environment: lead, particulate matter, stuff in the water, plastics. The list goes on. Climate change is a stressor. Being in Ukraine or in Gaza and being around conflict is a stress for pregnant women. The list goes on. But I want to share with everybody here that, again, the uncertainty principle. I don't know everything. And so when I approach the fetus or the newborn with a suspected neurologic problem, and everyone could think it's HIE, it could be from other things, stressors are multiple. So toxic stressor interplay, just understand your job as parents, if you can have more kids, is, plan your pregnancy as best as you can and support each other as partners when you are pregnant, but know that life is not going to change. You still have to bring in money to support yourself. You have things that are going to happen that could be illnesses in the family. Life goes on. So,
yeah, really helpful. Thank you so much. So I'd love to switch gears with the interest of time and everything to talk about, and I always dub it the elephant in the room. Okay. And that when families go out to seek information about HIE and causation, and why we had this blanket don't go to Google for so many years, and why we've worked so hard as an organization to try to make the internet a more friendly, accurate information place to be, is because the US, like many other parts of the world, South Africa comes to mind, the UK, Canada, a lot of the more high, although South Africa isn't a high income country, but a lot of the more high income countries, we have a highly litigious society. Mm-hmm. And I think it's very common for parents to go to these sites that look like they are vetted and, and understand that, like, when you go to a sponsored ad, they're spending a lot of money for those. And that we do have a lot of competition in the information acquiring field that might not be accurate. People get a sense that, a lot of these websites that are funded by attorneys paint HIE as like 100% preventable. And we do a lot of education to try to help families understand, like better understanding of like what standard of care is and why that's an important term to know. And I know you've done some medical legal work So I'd love to get kind of your perspective of like, the state of messaging and what you want families to know when they come across sites like this and things that they should be thinking through of like really to get to the bottom of what that information really is and that misperception that we battle, frankly, often as an advocacy organization. And that really drives barriers between families and getting answers many times.
Well, I mentioned the medical legal before, and I'll expand on it as much as you'd like, because I think it's important, again, to stress what I said before. Health providers are only human. We make mistakes. And if those mistakes are responsible or contributed to why your baby is injured, we have to, with our insurance, pay the price. That being said, I do medical legal work to try to explain to the lawyers who approach me, and I'm very open to anybody who calls me, whether it's a plaintiff lawyer representing the family or it's a defense lawyer representing the healthcare provider. Give me all the facts, because I'm a time traveler. I'm a retrospective reviewer as an expert witness who sees everything. That's the key, uncertainty. So when I review the records, I know about the placenta and the cord. I know about the imaging. I know about how the kid has grown up at an older age. And therefore, I give my advice retrospectively as an expert. The parents who are thinking about a lawsuit have to decide prospectively, was the healthcare provider aware of that? And could they have made the outcome different? The answer is probably not in most cases. That doesn't mean that errors don't occur. There's an Academy of Sciences in the United States. It was formed in the Civil War, during the Civil War. It is still active today, made up of engineers and physicists and doctors and bioethicists, all kinds of scientists. They have written two books that you can get online free. One is called To Err is Human, in 2000. And is that where
I have no idea how you're getting balloons, but they're really fun.
You know what? Because I did this. That's why. Oh. So, and then they wrote a follow-up book in 2015, which improves on clinical decision-making. If that decision-making has contributed to injuries, were they at fault because they didn't meet standard? I'm not a standard of care expert in OB because I'm not an OB. But I will share with you that you've all heard about the category 2s and 3s on fetal heart rate tracing abnormalities. Maybe you haven't, but if your OB looks at your baby's heart rate during labor, particularly during your contractions, and finds that the fetal heart rate slows down or the variability changes, many lawyers who are claiming that this is a reason for bringing a lawsuit, they're making an incorrect assumption that abnormality on the fetal heart rate tracing equals brain damage. It doesn't. It could. And OBs and nurses who see that get really worried, and they change the position of the mother. They give oxygen to the mother. They sometimes decide to do a C-section because they're worried about the risks for brain damage. But category 1, 2s, and 3s don't predict brain damage. So I'm not saying that people don't make mistakes. I'm not saying that we should not be held to a high standard and admit that and then pay money to support a family who has to deal with a special needs child. No, I get that. But it should be done honestly and intellectually and scientifically. Science is everything. The problem with science is that we unfortunately learned a lot of bad stuff about COVID. You don't give Clorox to people who want to avoid COVID. You don't give chemicals that are dangerous inside the body to prevent COVID. That's not science. Well, same thing is true. My only advice with all of this medical legal jargon is, if you feel you've been wronged, then you should really sit down with the treaters and try to get the information directly from them. If they can't give you what you can, then you have to go to the internet and find a law firm that's going to be honest enough. And there are some honest plaintiff firms and honest defense firms, as well as dishonest on both sides. But they need to get expert testimony from people like me to look at the record and say, yep, there seems to be a causation that could have been avoided during labor and delivery. If that's the case, then you have a lawsuit. Most of the time, and I'm saying this because of my approach to looking at these cases, the provider didn't know about the placenta or didn't know about the woman or dad giving genes to the baby that were abnormal. I don't know if you want me to talk about genetics, but those are all part of a defense argument, but they're not something that, because of uncertainty, a healthcare provider should be sued and have to pay money for. That's my honest opinion.
I really appreciate that. And this is like a question that always comes up. And I'm going to dovetail into next of follow-up is, again, being frustrated that there is so much misinformation out there of the people that are, because these are typically large scale awards if they are successful, and attorneys make, in the US at least, about 30 to 40% of that. So it's like a big score for them if they get one case or two, whatever. So they can cast the wide net and then see who comes in, and then they can figure that out. But what they've caused is this, I mentioned it earlier, the barrier where no one, it creates a significant barrier between the families and providers to have authentic conversations. And when I hear directly from NICUs that, like, there was a NICU last year that reached out to me to ask if we were going to change our organizational name because their neonatologists were no longer allowed to use the term HIE and had to use neonatal encephalopathy. And I said, well, where is that coming from? And they said, well, that was our risk department, right? Because they're like trying to decrease risk. And unfortunately, what this causes is this rift, and this families, I feel very confidently, and I'm sure I know you do as well, deserve as much information as possible about their child, right? To try to understand this. And we have a couple comments coming in about, like, how can you approach these conversations that you need to have as a parent to try to understand this better when doctors are so concerned about, have risk managers in their ear, or have this culture that is creating these barriers, because many providers do shut down or, aren't open because they're concerned because of this society that we have right now.
So I have a job as a teacher to make sure the next generation of doctors don't become so defensive that they won't communicate. Yeah. That's my job. And I will do my best to continue that. But Betsy, you invited me to join in this discussion today so I can reach across the aisle to lay people like parents who've been through kids who've had brain disorders such as HIE. Because I think I get back to my earlier comment of a shared decision-making that maintains compassion and trust. If I can do that by saying to the parent, did you ask your OB before you gave birth, could you please save my placenta? Even if it turned out to be Apgars of 9 and 9, I would love to see that. Now, a lot of hospitals don't have the money in their budget to examine every placenta. But I think it's if your organization can advocate for anything, for instance, it would be tell the parents when they are pregnant to advise their OB team to wait until the baby's been born because they may need to look at that placenta to give them answers. That would be a good way of being open and honest that we don't know all the information. The other is maybe we should be thinking about genetic testing. If your baby is sick in the NICU or stays sick after discharge, it may be important, even though we can't necessarily change the outcome for the baby who's got brain injury. But if you as a parent with your partner want to have another child, doing genetic testing is important. Now, genetic testing is not like Moses coming down from Mount Sinai giving you the 10 Commandments. It's not going to tell you everything. But if you do microarray testing, whole exome sequencing, these are special names for geneticists, you have a little more information of whether your baby may have had a vulnerability to have HIE or other types of brain disorders, or it caused them to have a brain disorder, whether it be a genetic disease as terrible as Tay-Sachs of the Jewish faith, or sickle cell disease, or I don't know, you name the genetic disease that can put you at risk at the time of birth. So if anything, I think that hope for HIE, whether you want to call it HIE or neoencephalopathy, is not important.
That's a whole other conversation.
A whole other conversation, but it is more important to maintain the lines of communication so you maintain trust. And that starts with uncertainty by being modest, knowing that God has all the answers and we don't, or she doesn't. And we have to be honest with that and approach problem solving together. And that's what I've tried to do in 40 years.
Yeah.
And more.
I know. And that's like one of our biggest advocacy points with providers. And I think with neurology, it tends to be a little bit easier because neurologists tend to see our families long term. So you already know that you're building a life, like a childhood long relationship, and that you approach things a little bit differently, I think, sometimes. And that's not to throw neonatology under the bus. It's just they're intensivists, and their long-term, their definition of long-term very often is like age 2 or age 3, because that's like the studies, that's where they go, or developmental follow-up. If they have one of those associated with the NICU clinic, that's how long it goes. And so I think, what I think we are working really hard on with Newborn Brain Society, with us as an advocacy organization with Hope for HIE, is bringing these disciplines closer together. So that way we, like you mentioned, the teamwork behind getting everyone in a room to have these conversations and move forward in a way that is, help things better in the state of care and communication with families. And I really want to, when you talk about the genetic too, something that we're going to post about, I just, so Dr. Yvonne Wu is one of the co-PIs.
I know Yvonne well. She's
yeah, of course.
Very smart lady.
And we had about half of the HEAL study cohort, another HEAL study out, like one with HIE specifically with EPO. We had about half the cohort in our community just naturally, find us. And, we've communicated a bunch about like the initial findings, but there's so many secondary analyses going on. And a paper that just is publishing now is doing the genetic analysis of those 500 babies. And, and I'm going to share the PDFs in our groups and our website, because Yvonne was so generous to share all the PDFs with me to share out to the families. But about there was a genetic paper coming out, and about 5% of the cohort had a genetic marker. So, which was really fascinating in this era of genetics. For a long time, we had a lot of families, because of what we knew at the time, people would, wondered about causation and would be referred to see if it was like a mitochondrial disease instead of HIE. Right. And, I can't think of a single family that came back with a positive, yes, it was mitochondrial disease versus HIE. However, we do now have, because the testing is more accessible and is more affordable, we do have a lot of families getting referred to genetics, and we do have some coming back with positive markers, which further explains a lot, and as an advocacy and support organization, we always want people to get the right support. So this also opens up, because we know the benefits of community. It opens up potentially, another community that's dedicated to better understanding their child. And with the genetic revolution, there's a lot of targeted therapeutic development that's going on, and timing is so critically important. So we talk about that bucket of neonatal encephalopathy. HIE is one bucket in the leading bucket, but those genetics are really important. And I know we're getting better in the NICU to, push genetic testing to better understand and identify those babies earlier, for hopefully targeted trajectory.
So, you've mentioned something, and I know we're past the hour, so you tell me when I should stop talking. But I think that you're absolutely right. You never stop being a healthcare provider, even after the age of 3 or 5 or 10 or 15 or 20. I mean, I'm a child neurologist, so I usually give up seeing the person when they reach adulthood. But, one of the things that I find so fascinating about children is they adapt, and some of them get better. It's called neurodiversity. We have a term called divergence. And so rather than saying your child is, quote, brain damaged, some kids will adapt. And so they'll have less of their abnormalities as they grow older, and they will adapt. And many of those are because the parents are so strong as advocates to get them therapies and all that stuff. and that's important. But getting back to genetics, please understand that the genetic testing we have is imperfect. It will tell you a positive result. And I will say this, besides Yvonne's study, which is very good, her phenotype was, I think, HIE from what you told me.
Mm-hmm. Yep.
Well, there's a different phenotype called cerebral palsy.
Mm-hmm.
So cerebral palsy is an older child, usually takes about a year to 18 months to make that diagnosis. If you look at a child with tone and posture abnormalities, there are world studies that Yvonne knows about that I'm part of indirectly. It's called the International Consortium of Cerebral Palsy Genetics Research.
Mm-hmm.
It is a group of scientists, about 200 of them, that have published information on adults and children with cerebral palsy, and they come up with about a 33% hit rate.
Yeah.
So
and HIE is like, again, it makes it there was also this misperception that like HIE and CP were synonymous for so many years, and like CP is heterogeneous. Yes. HIE is heterogeneous, and we actually only make up like 10 to 15% of all CP cases. So
one of the things that you as parents should realize is that if you have a neurologist and your primary care physician, make them think about your child's special challenges and consider genetic testing at an older age. And I'll give you two examples. Your child may develop epilepsy later, the need for medication to control seizures. That's one phenotype that is an abnormality that may have to do with fetal life or genetics.
Right.
The other is autism. Autism has very little to do with term babies having problems, but autism is very complicated. It probably has a genetic component, but it probably has a first half of pregnancy component. But if your child has autism or epilepsy, as two other examples besides CP, you should be thinking through with your doctor, shared decision-making, that maybe you should be going to a geneticist to get the panels of tests that look at reasons for epilepsy, reasons for autism. You may not come up with positive results, but I mean, I wrote a paper in 2022, which you don't have to read, but I basically found it important to tell those who I'm training. I changed my diagnosis when I started to see the kid after the age of 3 or 4, because I saw other things that made me get genetic testing. And it was an eye opener. So after I wrote the paper.
Yeah, I mean, it's really amazing to see this field accelerate and get better understanding. So people do have a better, again, like families aren't left with, greatly unanswered questions and have at least a hypothesis to make decisions forward, for their child. Wow, we've covered a lot of ground this hour. I am so grateful for you taking the time to share your expertise with our community and tackling what is, and will likely continue to be one of the biggest challenges, which is the why behind HIE. But I know, we're focusing a lot on research this month in particular, and there's a lot of exciting things going on. We announced that we're working with the Cerebral Palsy Research Network to build an HIE registry. We're, doing all sorts of things that there's a lot of exciting research with HIE happening that we're talking about, and really hoping to inspire our families to have this call to action to get involved when we have these calls, to better understand. And that's how we will help, understand that, gestational component of, opportunities to intervene and prevent, which is the ultimate. But I don't know if we will likely ever fully solve the puzzle of prevention for HIE, but certainly there's headway that we are making and will continue to make out there in the landscape. And I am just so grateful again for your participation today. I love talking to you. I'm going to hear you for hours. And I know
I'm going to be in San Diego, so maybe the two of us can have coffee together. So
that would be great. Would love it.
So my only hope is, because I know you have a couple of questions I didn't answer, is if you feel as though my information was helpful for you, you can always, through Betsy, contact me. And I'll try to answer your questions if that's okay with you, Betsy.
Absolutely. And we'd love to have you on again, as.
Sure. So my only hope is that I haven't confused you. My hope is that I'm trying to train the next generation to say the right things, and not to say the wrong things. And that's why I'm involved in the Newborn Brain Society.
It's amazing work. Your expertise shared today, it was just so great. We had such wonderful engagement with our families, and this will be available afterwards as well, so families can go back. Deanna always creates a key takeaways blog and social media squares, so that way people have access to this important information later. So thank you all who have joined us today. So many good questions that came through, and Dr. Scher, thank you, and we'll talk to you hopefully soon. All right,
Very
thanks
good.
everyone.
Everybody have a good day, and thank you so much, Betsy, for inviting me.
Thank you.